My name is Sabrina Bajwah. I'm a clinical academic, so I work as a palliative care consultant at King's in South London, but I'm also an academic at the Cicely Saunders Institute. So I'm here today, excuse me, to present some of the work from CovPal, which I think you've heard quite a lot of today. And specifically, I'm presenting the work related to ethnic minority groups, which we collected during this time. So the aim of what we tried to do within the CovPal work was to map and develop insights into the response of specialist palliative care services for ethnic minority patients and carers during the COVID pandemic. And we did this through a cross-sectional survey, which you've already heard about today. And we gathered data which was both quantitative and qualitative in nature. So specifically, the questions within the survey, which I want to reflect on today, included, have you encountered patients or families with COVID-19 who are from Black and minority ethnic groups? Are there any differences in how you are supporting or reaching them? And are there any groups, different religions or cultures, where you have found supporting the individual needs of people affected by COVID-19 particularly challenging? So in the survey, we received responses from 277 UK palliative care services between April and July of last year. And I'd just like to say that we're extremely grateful for the fact that 168 of these services were UK hospices. So thank you very much for completing. So of the responding organisations, 34%, that's 93, had cared for patients and families from ethnic minority groups. So unsurprisingly, the greatest number of services supporting those from ethnic minority groups were in London, the South East, North and the North West and the Midlands. So, interestingly, only 23% of the responding inpatient hospice palliative care teams, 30% of the home palliative care teams had actually looked after ethnic minority patients during this time. And this is in direct comparison to 49% of the responding hospital palliative care teams. So services who had supported those from ethnic minority groups were significantly more likely to have had hospital palliative care teams and less likely to have had inpatient hospice or home palliative care teams. So from our qualitative work, a number of themes emerged. So whilst everyone suffered from not being able to see their loved ones at the end of life, respondents noted that during the pandemic, families of patients from ethnic minority groups were particularly affected by restrictions on visiting. These were blanket restrictions brought in on an emergency basis. So services reported that families struggled as they were unable to fulfill their religious and cultural responsibilities at the end of life. And Jamila touched on this, and certainly within the Pakistani Muslim community, you have two Pakistanis here today, but it is normal that we would, in large groups, make decisions together and actually take an autonomous decision as a family together and really be available to provide physical support to somebody at the end of life is really paramount in our culture. So services reported that visiting restrictions appear to have a disproportionate adverse impact on ethnic minority groups. And these are a couple of quotes which I'll just let you read. So our data demonstrated that visiting restrictions may not only have removed patients' psychosocial support and advocates, but also their personal and professional translators. For many, their only means of communication. So I am bilingual, and when I went to school at the age of 4, I couldn't speak any English, but luckily I can fully communicate now in English and be able to communicate my needs. But there are many ethnic minority groups that can't do that, and as we know, verbal communication at the end of life is essential to not only communicate what your needs are, but to actually have discussion about prognosis and really think about treatment and care. And for these patients, they had their face-to-face translators removed, and actually translators weren't available in hospital or hospices because of the infection risk. And for these patients, it was extremely difficult for then to communicate via telephone translators due to PPE. So similarly, policies introduced prohibiting physical contact with loved ones after death may have disproportionately impacted ethnic minority groups who are more likely to have contact after death with the washing of bodies and the prayer in large groups, which is often actually thought to help the person go to heaven as well. So services repeatedly stress the challenges in managing the distress for families related to these policies. So theme 4 was related to mistrust of services. So services reflected mistrust was present in some communities, embedded with cultural and religious values. And then there was also a suggestion that general mistrust of healthcare services, which services suggested was related to previous poor experience. So our theme 5 was a focus on equal and personalised care. What was incredibly interesting for me was that when services were asked if there were any difference in how they supported or reached ethnic minority groups, 66%, that's 61 of the 93 services that had looked after patients and families from ethnic minority groups, indicated that they hadn't adopted a different approach and all patients had been treated equally. So this view of equality seemed to be supported by the perception the assessment of patients' needs was personalised and that any care subsequently delivered to them was therefore appropriately matched to their needs. So I just want to really highlight the positive examples that were noted in the qualitative data of services reaching out to external faith groups to support patients to reduce the impact on ethnic minority groups. So some services explicitly stated they were well versed in serving a diverse population and already had established links with their local ethnic minority groups. So for some services, there appeared to be little consideration about issues that didn't go well. And for example, if the challenges associated with poor communication were considered, the responsibility to resolve this was placed with the patient and their family and not with the service. And there was a lack of self-reflection on how services themselves could improve. So our findings from this work, and this is a table from the publication in BMJ, Supportive and Palliative Care, and it really suggests that at the moment within palliative care we have a perception that we're delivering equal and equitable care to ethnic minority groups, and we have a bar of high quality palliative care and outcomes for these patients. But actually the reality is that we're unable to deliver that bar of high quality quality palliative care and outcomes, because we can't respond to cultural and religious needs. And part of that is the impact of policies which are brought into place. So in our paper, we really consider what we need to do to address these needs and reach that high bar of palliative care outcomes. And I'm keen today, really, not for us to sit here and talk about how bad the problem is, but actually give you ways in which you can improve the situation. So, of course, we've all for many, many years, had the focus of palliative care delivery with personalised care at the heart of it. And I think that is incredibly important that we continue to do that. But in addition, we need to think about how our policies impact those groups, and we really need to consider that. And one of the ways that we can do that is by actually conducting equality impact assessments of any policies that we have in place or before we change policies. And it's really important that those people who conduct those equality impact assessments are of a diverse group of people, because otherwise you will get a very blinkered assessment. It's really important that those groups that you are trying to improve outcomes for are included in actually developing your service. And we need to think about how we're distributing the resources within our hospices and palliative care services. And fundamental to that is actually data. Data is incredibly powerful. We don't know that we are delivering equitable care until we go and look for it. So for the first step would really be to make sure that you are defining ethnicity appropriately for each of your patients. So ethnicity is a self-identified characteristic. So you need to ask your patients how they identify from an ethnicity perspective, and then actually collect data around outcomes for those patients as well as your overall population to see whether there is equality and equity in the service that you deliver. And we need to deliver culturally congruent care. So for me, I have a big passion around the language that we use. So language is incredibly powerful. So we've used ethnic minority, the phrase ethnic minority, throughout this paper, and that's because it was recommended at the time. But even that language, calling a group a minority is in itself a microaggression, because you are the majority. So it makes me reflect on all the language that we use, that the hard to reach, the difficult families, and you know, they're not really difficult families. Actually, they're families with a different belief system. So I think really reflecting on the language that we use is a journey that we all need to make. And importantly, I think we have all grown up in a society and live in a society where the white British way of dying is the dominant way of dying, and almost the way of dying that everybody is stamped with. And actually, for us from ethnic minority groups, it's not necessarily the best way to die or the way we want to die. So it's important that we start to think about centering at the margins, so really thinking about what the people who aren't in the dominant culture may want. So the last 18 months has completely changed me. So I've worked in palliative care I've been a palliative care doctor for probably 18 years and a consultant for 12 years. And I think that the last year, working at King's, we were hit really full on by COVID, and we had over 400 patients referred to us in our palliative care service in the first wave, and we are really lucky to have a 50% ethnically diverse local population, and it's an extremely deprived socioeconomic population. And actually, seeing those patients die in the way that they did, and seeing the inequality in the service that they perhaps received, and actually seeing how these patients weren't able to communicate with their loved ones in the same way, or losing their translators and having impact of policy has really opened my eyes. And for me, I think that you see, seeing as well the impact on personally and on the community that I live in has really changed my outlook forever, really, around racial inequality. I think we've all got an opportunity, really, to change what we do and how we practice, and I know that I will be changing everything that I do going forward. Once your eyes are open to racial inequality, you never stop seeing it. You see it everywhere. And I think we would like to ask you to all be allies and advocates in this cause. Thank you.